Hi there everyone, welcome to the first of our Medi Summer School bite-sized sessions. My name's Rachel and I'm a clinical trainer with Medi. These sessions are designed to run throughout the summer. We know how busy you all are, so we still wanted you to have access to education and learning throughout these busy times. This is a short session, so please feel free to reach out to us afterwards for any educational training. We're really happy as clinicians to come and see you in your clinical settings and talk to you about what we're talking about today, but also the Medi wider range. Today's focus, we are focusing on one patient case study and one key product, which is our UCS debridement. Thanks everyone for taking the time to attend. Hopefully you'll be able to take away some ideas to put straight into your practice to benefit your patients and to benefit you. So today's subject, we're talking about clearing the path for wound healing with effective wound bed preparation. We know how huge the costs are to the NHS for unhealed wounds, trying to manage these unhealed wounds. And we also know what a massive strain that puts on services. So we need to be taking a really proactive approach. And if we're doing consistent wound bed preparation, that's being proactive and that's going to make a difference to these unhealed wounds. So the patient that we're going to be talking about today, we're going to be talking about the importance of effective wound bed preparation, the clinical reasoning behind key treatment decisions made by the clinicians, and how these decisions supported wound healing and improved the patient's outcome. So let's meet our patient. This is David. David's a 56-year-old male. He has type 2 diabetes treated with metformin. He has an active lifestyle and he works full-time, 6 to 7 days a week, and most of this is on his feet, so he's really up and about all week. Unfortunately, he has a 9-month-old deteriorating leg ulcer. This started as a spider bite. And during this 9-month period, he's had recurrent wound infection, which has needed antibiotics, and he's had severe pain. This was David on day one at his leg ulcer clinic appointment. The team did a holistic assessment. They did an ABPI, which was within normal range, and so they were able to apply strong compression, which, as we know, is gold standard care. So when we're looking at this wound, you can see it's very chronic in nature. We can see it's extensive on his lower limb. So let's have a little talk about what we see. Tissue type. So we can see that there's lots of stubborn, adherent, thickened slough present, and any of the other tissues that are in the wound don't look healthy. We can see that we know that he's had a history of recurrent infections, but we can actually see here that the skin is red and inflamed, suggesting ongoing inflammation and infection and a very high bacterial load. His moisture levels, exudate levels are high, so these need better management. The wound edges are macerated and inflamed due to that excessive exudate, and we can see the surrounding skin and the peri-wound are also inflamed, again reflecting poor moisture balance within the wound. So when looking at a wound like this, or maybe you're thinking about some people in your own practice, we need to identify what the barriers are and we need to clear them. That's how we are going to be clearing this pathway to healing. So we need to be looking at the physical barriers. So with David's wound, the physical barriers are the sloughy, devitalized tissue and the bacteria that's present, and that needs to be physically lifted away from the wound. Then we've got the more biological barriers, the increase in bioburden, biofilms and infections. The repeat infections that David's had and the lack of progression with the wound it tells us that there's likely a biofilm present. That's what's making the wound static and hard to heal. So we need to disrupt that biofilm, that cellular matrix which prevents the dressings, including antimicrobials, or the dressings that help with autolytic debridement. It's stopping those from actually penetrating the wound bed. We know David's had this leg ulcer for 9 months, so the team needed a plan. Relying on autolytic debridement alone can take a long time, but it's also, like I've said, more difficult with these types of wounds with that biofilm presence. Another consideration was conservative sharp debridement, but unfortunately this was not available in the clinic at this time. The team decided to implement a debridement pathway, and because of past use and past success stories, they chose to implement the debridement pathway using the UCS debridement. So I'm going to tell you a little bit about the UCS cloth. It comes in a cloth and a glove. It's a one-step, easy, simple approach, and it overcomes those barriers to healing. It's single-use, sterile pouch, and it's pre-moistened, so you don't need any saline, any water. Everything you need is in the pouch. So it has some unique features as well. When we talk UCS, we talk debride, cleanse, and hydrate, because that's exactly what it does. So this is the cloth. And within that cloth, there's a soft gentle soft loop technology, and that traps and lifts away those stubborn tissues like David has. So that's actually physically removing the devitalized tissue and the bacteria and taking it away from the wound. It also cleanses, so the cloth is ready to use, and all the solution that's entrapped in this cloth has an active solution with a surfactant in it. This includes poloxamer, which is amazing at providing deep cleaning to the wound and breaking down the biofilm presence and reformation. UCS is particularly great at this because it keeps working until the next session, so it helps to break that cycle of chronicity. The solution also contains allotoing, which is a softening agent. It works well on those thickened tissues which need removal. The mechanical action of the cloth, enhanced by the softening agent and the surfactant within the cloth, all work together and get the job done. It also hydrates. The allotoin adds moisture, which encourages that autolytic debridement. There's also aloe vera present. So this helps to soothe the wound for the patient and also helps to reduce inflammation. I'm now going to show you a short video of it in action. As you can see, the clinician here is using it in a polishing technique. That's how we use the UCS debridement. You can see all of that solution, all of that surfactant that's being applied to that wound bed and that surrounding skin. That's what's going to break down those stubborn tissues and that dry wound edge. When the clinician takes it away, and this is just them doing it for a few seconds, but you can actually see that devitalized tissue coming away with the cloth, and actually think about how much bacteria is being removed at the same time. And also, if you notice in the wound, those little pinprick areas of blood that you see within the granulation tissue, that's that granulation tissue coming back to life. That's what we want to see. So if we go back to David now, let's look at day 10. So what we're doing is we're bringing this wound out of a chronic state. You can see this by the difference in colour. The thickness in the devitalised tissue is less, and it shows us we've disrupted that biofilm, and we need to keep doing this at each treatment. This isn't a one and done. This needs to be ongoing until we get on that route to healing. Exudate levels have reduced. We can see this by less maceration at the wound edges and improved condition in the surrounding skin. So now we've started to soften and break down those stubborn tissues and that biofilm, we need to go forward with physically removing the remaining sloughy tissues with using our UCS cloth, and we need to mechanically debride the wound, in addition to continuing to penetrate tissues and encourage granulation formation. Now look at week 4, what progress. So you can see this is happening. The UCS has lifted those tissues and any bacteria away from the wound, and we're seeing healthy tissues. It's really important to note that David had ongoing infection over that 9-month period. In this 4-week period, he had no infection. So that shows us we're actually taking that bacterial load away from the wound and avoiding those infections from building. So we can see we've also successfully stopped that biofilm reformation because we're actually accessing healthy granular tissue. The clinical team reported the slough was visibly lifting away at each debridement, showing the effectiveness of this treatment pathway. There's no maceration now present, so the UCS has helped to balance the moisture of the wound in a positive way. We can see the wound edges and the surrounding skin appear much healthier with reduced inflammation. And David had, very importantly, less pain. Think about this chap working 6 to 7 days a week on his feet with a 4 weeks prior to this, he had a wet, weeping, infected, painful leg, and 4 weeks into a really proactive treatment plan using the UCS, and think about how much more positive his mindset must have been. He was also able to self-care at this point. So if he couldn't attend clinic, because the UCS is so easy to use, he was able to do his treatment at home. So he wasn't missing out on those debridement opportunities. Let's skip forward now to week 7. Look at that wound. Look at the difference from his initial presentation. We can see healthy granular tissue. Wound margins have reduced. The whole leg in general looks more healthy. So we've used the UCS to remove those barriers. The barriers you can see in that first image, we've actually removed them. We've disrupted the biofilm. We've mechanically and physically removed the problematic tissues, and we've reduced inflammation. And we need to keep doing this to ensure we keep that cycle of chronicity broken. So let's just recap about UCS debridement. So as I mentioned before, when we think UCS, we think debride, cleanse and hydrate, because that's what it does. Other things about the UCS debridement, it's very soft. So that soft loop technology, it's gentle to patients. And so patients with pain like David that might be intimidated by the thought of debridement, or, it can be a scary thing for patients because it's the unknown. But when you've got such a gentle tool and the solution already starts breaking down those stubborn tissues without even doing that polishing motion at the beginning, you can actually build confidence with patients and get them engaged and less intimidated by using such a gentle tool. It also has a really large surface area, so you make the most out of it, make the most out of what you've got. So if you're using one side of it to debride, say for example David's ulcer, if you've got some skin that's dry to the rest of the leg or any hyperkeratotic areas, flip the cloth over and use it. Really make the most out of it. And it can be used after bucket washing. Remember, we wouldn't use it before bucket washing because that surfactant, that solution, continues to work and continues to avoid that biofilm regrowth. So we don't want to wash it away after we've used it. We need to let it do its thing. So if you're bucket washing your patients, that's amazing, but that isn't debridement. It needs to be used in conjunction with. And it can also be used on any wound. So my personal favourite, I love it on cavity wounds. I love that because I'm in charge of the cloth. My sterile gloved hand is in charge of where that cloth goes. So I know that I'm addressing all of the wound bed area that I need to. It's great for those really tricky, hard to get to places. It's brilliant between toes. Again, with how gentle it is, patients tolerate it really, really well. And let's not forget self-care. So like with David, he was able to, because it's got everything you need in the pouch, he was able to do his own treatments at home between clinic appointments. And so not missing out those debridement opportunities, freeing up space in your clinics. All of these things make it such a great tool to have. So let's go back to David and talk about how we've cleared the path for wound healing by using the UCS. We know he's had an 80% reduction in slough over that treatment period. That's created an optimal wound healing environment. He's had no further infections. We've reduced the bacterial burden and the biofilm and prevented further episodes of infection. And so therefore, no more antibiotics for him, no more cost to the NHS for antibiotics. He's had a significant reduction in pain. And he's returned back to his active lifestyle. So all of that together, think about the improvement on his quality of life. And ultimately, this has led to healing a very, very chronic wound. This case study is just one example of the amazing results that we've seen using UCS. And it shows us that we can heal wounds more quickly. We need to clear the path for wound healing with effective wound bed preparation. That's the end of our first Medi Summer School session. Thank you everyone for watching, and please reach out to us with any questions, and please sign up to our next summer school sessions. They're all going to be fabulous. Thank you.